Hello, my name's Alan Francis. Thanks for joining us today. I'm a professor emeritus, former chair of the Department of Psychiatry at Duke University. I was chair of the DSM-4 task force. With me today for what I think will be a very interesting interview is Judy Beck. She's the president of the Beck Institute, and I think probably in my experience, the most magical person I've ever met, and a great trainer of cognitive behavior therapists. I have to admit to a great deal of bias in this interview. Full disclosure, I'm not a neutral interviewer. 40 years ago, I was on the panel at NIMH that approved the first grants in cognitive behavior therapy. And at that point, I was intrigued with it, partly because I felt I was doing it without knowing it, partly because it was, I thought, a tremendous clinical innovation, particularly because it could be easily taught and easily learned. It could be done in a short-term context. It was a terrific research tool, and it would bridge the gap between research and clinical practice. It has, in its performance, cognitive behavior therapy has far exceeded any of my imagination. I think that in the 200-year history of modern psychotherapies, there's never been a treatment that has done nearly as much to help millions and millions of people, tens of millions of people. And one of the intriguing and wonderful things about cognitive behavior therapy, unlike most psychotherapies, is it keeps changing. It keeps advancing, expanding its indications to more and more patient conditions, expanding its technical repertoire so that it can do more for the people it treats. Now, Tim Beck has always been one of my heroes, and his daughter proves that genetics works. His daughter has the same kind of combination of intellectual rigor, emotional empathy. They're both great therapists. And I'm very much looking forward to this opportunity to find out more about the latest developments in cognitive behavior therapy. So, Judy, why don't you take it from there?
Great. Well, Alan, the field owes you a great debt for promoting CBT and funding its first outcome study. So that was back in the 1970s. And my goodness, how CBT has grown and flourished and changed since then. Although the basic cognitive model has never changed. You know, the cognitive model says that it's not situations that directly impact people's reactions. It's their perception of situations, what they're thinking about, that's more closely connected to how they feel and what they do, and sometimes to their physiological arousal. And one really important part about cognitive therapy that has remained constant is that one commonality among people who are suffering psychiatric disorders or psychological problems or many medical conditions with psychological components is that they have some distorted thinking. Now, traditionally, what we have done in cognitive behavior therapy is to turn our attention to experiences in which clients feel very distressed or act in a way that's just not all that helpful. And we teach them to elicit their automatic thoughts, the thoughts that just seem to pop up into their heads that led to this reaction. And then sometimes, not all the time, but sometimes we would help them then evaluate their thinking, not challenge their thinking, but look at the evidence that their thinking was accurate or not accurate, look for alternative explanations and so forth. More recently, and this is what I have put in the third edition of Cognitive Behavior Therapy Basics and Beyond, is more of a recovery orientation, where we really are focusing more on people's positive experiences and their positive emotions and their adaptive and helpful thinking that lead to this more positive reaction.
Could you go into more what recovery is like and
Sure.
how it smoothly complements and integrates with cognitive behavior therapy?
So the recovery movement started maybe about 50 years ago, maybe in the United States, but I'm sure it's really international as well, with the idea that people who had, especially people who were diagnosed with serious mental health conditions, weren't being helped very much by trying just to decrease their symptoms, but rather a different orientation was developed, and that was recovery. So recovery really means when people are living the life that they want to live, when people are find meaning and purpose and a sense of safety and control, a sense of competence and worth. And those aspects of people's experiences are very much cultivated and emphasized, and really the negative symptoms, negative experiences are de-emphasized to some degree. One of the goals is to help people who are in a disconnected mode, or you might say a depressive mode, or just an unhelpful mode of being, is to help them get into the adaptive mode. And once they're in this adaptive mode, then you see their thinking is much more helpful, their behavior is much more helpful, they're able to solve problems much more, they're much more motivated, they feel so much worthwhile, and so forth.
How does that work in practice? How do you combine the recovery aspiration with the techniques of cognitive behavioral therapy?
So my father, Tim Beck, or Aaron Beck, as probably most people know him, has been working for about the last 10 or 12 years with colleagues at the Beck Institute in our recovery-oriented cognitive therapy program to bring this recovery orientation to people, as I mentioned before, diagnosed with serious mental health conditions. They work both with higher functioning individuals who live in the community, but especially in recent years, they've been working even more with people who may have been hospitalized in a psychiatric hospital for 10 or 20 or even 30 years. So I'll talk a little bit about that first, and then I'll talk a little bit about how we apply some of the same principles when we're working with our outpatients at the Beck Institute. The first challenge in working with patients who have been hospitalized for so long is kind of twofold. One is engaging the patients themselves. The other is engaging the staff of the hospitals, because sometimes they have really just given up on these individuals, believing that there's nothing more that they can do for them. So we very much have to work with the beliefs of the staff of organizations. And one of the ways to do that is to ask the staffs to describe one of the individuals they're working with who pose the greatest difficulties for them. And then they ask the staff, when is this individual at his best? What kind of situations? When he's at his best, what does he look like? What is he doing? And what do you think is important to him? And then they teach the staff how to better engage the patient through experiences, through creating experiences that can bring a sense of pleasure or accomplishment to these individuals. Sometimes they have to engage them just by playing Name That Tune, or by taking them down outside to the basketball court and engaging in that kind of activity, taking a walk to McDonald's, and then really talking to them as people, not as patients, but finding out what they're interested in, what their opinions are. One wonderful way to do this is to find out what some of the individuals' talents at least had been before they were hospitalized, and interview them. Show interest in that. If the staff themselves can find something that the patient is better at than they are, that's a wonderful way then of trying to equalize the relationship. So having engaged the patient, then they ask the patient what their aspirations are, what they really want for their lives, what are their hopes and dreams. Or if that's difficult for them, asking them before they got hospitalized, what was really important to them? What did they hope for in their lives? And then they get them to visualize these aspirations, really creating a very strong visual image in their mind, trying to use all of their senses. And then they interview them about this image, what's happening in the image, What are they doing in the image? Are there other people in the image? What are they thinking in this image now that they've reached their aspirations? What's particularly good about this image? What does it say about them? What does it say about how other people are treating them? What does it say about their future? And it doesn't really matter with these patients who've been hospitalized, whether the aspirations are realistic or not, because what they really want to get to is what's the meaning of the aspiration? What's so important about that aspiration? And then they talk to the individual about what the individual could do this week, right on the ward, to try to get some of that good feeling, to get some of that sense of purpose and meaning. And there's a lot more to it than just that, but that's basically what it is. And again, it's setting up these experiences where these individuals are able to draw positive adaptive conclusions about themselves. And they find that when these individuals are in these kinds of experiences, and when the environment has changed, when people are responding to them differently, they really get into the adaptive mode. And as the pile of experiences kind of builds up, they find that they're more and more and more in the adaptive mode. And many, if not most of them, have been able to move down to a lower level of care. Sometimes getting out of the hospital, sometimes living in a protected shelter outside of the hospital. And it just revolutionizes their lives in some way. So that's just a very short description of some of the things that they do. Should I tell you a little bit about how we apply that to our outpatients?
Just in a moment, but it seems that you and Tim are embodying what Harry Stack Sullivan said. Even the sickest amongst our patients are more simply human than otherwise.
Yeah, well, I think that's exactly right. And that's what we try to get the staff of these hospitals that we're working with to see, that they are human. And we try to depathologize their symptoms as much as possible. In fact, the people who have been in the hospital want exactly the same kinds of things as you and I do. We want to have good relationships. We want to have a sense that we're being competent and productive. We want to have a sense of purpose in life. It's really exactly the same things as everyone else wants. And it seems a little mysterious sometimes when you look at their delusions or their hallucinations. But if you look for the meaning behind these delusions and hallucinations, you'll find frequently it's these individuals' response to trauma, to feeling scared, to feeling unsafe. So they develop a lot of coping mechanisms which just aren't all that helpful to them. But when we put them in these supportive, positive environments, they find they don't need to use those coping strategies anymore.
Yeah, I was trained in a biopsychosocial model, but along the way, I added the fourth thing, the biopsychosocial spiritual model.
Yes.
People need meaning in life, and therapy, if it's going to be effective, has to help provide it. Different meanings for different people, but each person has to find his own way and his own meaning to make life worthwhile.
That's right. And I'm afraid that we didn't emphasize that enough at the beginning of CBT. And I don't think we emphasized enough the focus on not only alleviating symptoms, but also trying to create positive emotions right in the session itself and help people organize their weeks as much as possible to continue to have positive experiences.
One of the things that's absolutely amazing and wonderful about CBT, again, in comparison to all other psychotherapies developed in the last couple of centuries, is how much it's changed.
Yes.
And your dad is in his 90s, and he's coming out with a book next month too, or very soon.
Very soon, yeah.
He's been able to change his thinking and adapt to new patients, new disorders, new ways of looking at things throughout his whole life. What about CBT? What about the two of you have made you so adaptable, do you think?
Oh, I always think genetics plays a big role. But talking about my dad, who's now 99, by the way, and still going strong. I was visiting him at his apartment a few days ago, and he was talking to me about some of his latest theories about identity disorder and bipolar disorder. Just fascinating. In any case, I think one of his greatest characteristics has been that he's always been very curious, but he's also been very scientific. And he didn't take, say, the psychoanalytic dogma at face value after a few years of having been steeped in it. He had decided that what he really needed to do was to demonstrate to the world, especially to the scientific community, that the concepts behind psychoanalysis were valid. He thought this was really needed if psychoanalysis was going to gain currency in the more modern scientific world. So he did a series of experiments which did not turn out the way that he thought they would. And I think you said what qualities in my dad made for this adaptability. I think it's when he gets information that doesn't go along with whatever he had been thinking or the thinking of the field at the time, that he questions it. He doesn't take it on faith and does more research to find out whether there are better explanations for the observations that I think both psychoanalysts, and CBT therapists make.
I trained as a psychoanalyst and taught the Freud course at the Columbia Institute for 10 years. And one of the things that I speak to in psychoanalytic circles is that the greatest tragedy for psychoanalysis was rejecting your dad. He was trained as an analyst. I think he would have enjoyed being accepted as a sort of extension of psychoanalysis rather as a competitor. And what happened was that the psychoanalytic movement solidified around a 19-pen model. It hasn't changed very much and is, in effect, more or less dying on the vine. Whereas your dad would have been a wonderful extension if they had, instead of putting up barriers to him, had invited him in. If CBT were seen as a psychodynamic therapy, which it could be seen as, it could be an adaptation of psychodynamic principles to new problems and new ways of seeing things. Psychotherapy in general would have been enriched, and it would have saved psychoanalysis as an important contributor to our intellectual discourse and to our treatments at this point. The big mistake in psychoanalysis was not making your dad one of the leaders of the future.
And I think actually what has also happened is that many psychodynamic psychotherapists now use many CBT techniques in their work. And especially when we're working with in CBT with clients who have personality disorders, we do tend to spend more time in the past and trying to figure out how it is that our patients develop certain beliefs about themselves and the world and other people, and how that's affecting them today. Although I think I might have a different answer for you in 5 years, because also in our work at the Beck Institute, when we're working with clients with personality disorders, we're tending to spend less time in the past and much more time on this recovery orientation, just helping them get the life that they really want. Although sometimes having the insight as to why they have some difficulties is important. I think it's just important for people in general and also for patients to have kind of a coherent story about why they are the way that they are, why their life has gone a certain way. And so I think that there are certain ideas from psychoanalysis which can be helpful in that aspect. I think, of course, what CBT does, and especially recovery-oriented cognitive therapy, is to say, okay, so that's now we have an understanding. Of course you believe this about yourself. No wonder your life has gone this way. But now what are we going to do about it? How do you want to be different? How do you want your life to be different?
I think any complete therapist should feel obliged to learn all the different techniques, because no one technique works with every patient or even in the same session with the given patient. Yeah. It's important to be able to apply cognitive techniques, behavioral techniques, psychodynamic techniques, and understandings, and as well as systems and family and group techniques in the way you see the world and the way you see individual problems. Now, perhaps we can get to how does the recovery model apply to people who are healthier who are seen in an outpatient setting?
Okay, so one difference is in the first session. So instead of starting out by setting goals, we tend to start out now by identifying values. And we're incorporating a number of techniques, as you were mentioning, from other modalities such as acceptance and commitment therapy in this case. So we help people identify their values, what's really important to them in life. And we go through just a number of categories to help them figure that out. And then we talk a little conversationally with them about that. Why is family so important to them? What does it mean to them? How important is productivity? In what ways do they want to be able to express their productivity, for example? So we start out with their values, then we talk about their aspirations. How, again, the same kind of questions. How do they want their life to be different? What do they want it to be like? What are they really hoping for? And then we ask some questions. If they were able to lead this kind of life and be that kind of person, what would be the best part about that? What would it mean to them? Why would that be so important to them? And then having identified the values, then we start talking about, so what might be some of the goals for treatment, some specific ways that you'd like to be different or you'd like your life to be different as a result of treatment. So we start out therapy a little bit differently. And in each session, there's a slightly different model. Still based on the cognitive model, but the content is a little bit different. In traditional CBT, we set an agenda at the beginning of every session after we do a mood check and so forth. And we say, what problem or problems do you want my help in solving today? In the recovery orientation, we're much more likely to say, what are your goals for today's session? Now, the goals are actually the problems, the flip side of the problem. So the problem might have been, I'm feeling really lonely, and now the goal might be, I want to have more connection. And so we identify the goals, prioritize them, and let's say we start working on the first goal. And then I want to get back to what we do differently at the beginning of sessions. We identify a goal, and we ask the patient, what steps would you like to take this week toward this goal? And we help them identify some specific steps. And these steps are always aligned with, we ask them, how are these steps aligned with your values and your aspirations? Because that's very motivating for them. And then we talk about what obstacles could get in the way, what practical problems, what lack of skills, what cognitions could get in the way. And then we use our standard CBT techniques and techniques from other modalities to help respond to those obstacles. So rather than putting the focus on problems that the patient has encountered in the past week, we're more likely to look ahead to the coming week. What do you want to be different about this week? What obstacles are going to get in the way? So that's one difference. Let me tell you a little bit about another difference at the beginning of sessions. So traditionally in CBT, at the beginning of sessions, we would do a mood check. Now, if we're de-emphasizing the assessment of negative symptoms to some degree, but we're still giving out the Beck Depression Inventory and scales like that, or scales in the public domain. We're not quite ready to give them up yet, but we also ask them to assess their sense of well-being on a scale from 0 to 10 currently, and what was the range in the past week. So we definitely want to put an emphasis on well-being. We also have traditionally asked for an update, what happened between last session and this session that I should know, and also what's coming up between now and next session that I should know. When we ask those questions, then patients undoubtedly will tell us the negative things that happen, or negative experiences. When they do, we also want to make sure to say, well, what were some of your positive experiences this week? When did you feel even a little bit better this week? And then we probably are going to spend more time at the beginning of sessions going over people's action plans and their positive experiences. So often the action plans is what we used to call homework. And those are the steps that the client had identified at the previous session that he wanted to take in alignment with his aspirations. So when the patients have successfully completed an assignment or had some other positive experience that they reported on, we ask them, what does that mean to you? And especially, what does that say about you that you were able to do this? Or what did it say about you that this person had such a positive reaction to you? If they have difficulty with it, then we might offer it. I wonder, do you agree? I think that the fact that you were able to go out for a walk this week when you couldn't do that last week really shows that your motivation, you must be a little bit more motivated, that you were able to push yourself a little bit more. Did it show you that actually you're starting to be able to take a little bit more control over your life than you thought you could before? So just to summarize, what's a little bit different in treating the outpatients is we start with values and aspirations. We find out the best parts of those things and the meaning to the patient. We have them imagine it and try to experience that positive emotion right in the session itself. And then use that as a bridge to how can we help you get some of that positive emotion and positive experience this week? What steps do you want to take?
You said it was a little difference, but sometimes little things have tremendous impacts. And what you're doing is switching what's foreground and what's background,
Yes.
Starting with meaning and aspiration and goals, and then getting to symptoms as obstacles to realizing those meaning goals. But that shift may make all the world of difference in terms of the kind of relationship that's formed and how the therapist and patients feel about each other and how they work together.
I think that's right. We're collecting some data now. So our sense is there have been studies with individuals diagnosed with serious mental health conditions to show that this is abbreviated CTR, recovery-oriented cognitive therapy, that CTR is effective, and now we're starting to collect that data at our clinic.
Does anything get lost in the traditional CBT model, starting it within this framework, or does it pretty much have the same impact, only in a different context and frame?
So I think in 5 years we'll have a better answer to that. I don't think we've lost anything because there's nothing that we do in traditional CBT that we couldn't do in a recovery orientation. It's more, I think, a real shift of emphasis.
Yeah. How hard is it to learn?
Well,
how to teach.
So we've only started. There are two answers to that. One is the recovery-oriented cognitive therapy program that it's now at the Beck Institute has been teaching this in inpatient settings and also in outpatient settings for individuals diagnosed with serious mental health conditions for several years now. And they've had great success in being able to train staff really at all levels in how to do this. We've just started applying this more in our outpatient clinic and have now been teaching it in all of our online courses and now all of our workshops, which happen to be virtual at the moment. And I've also infused it in the third edition of Cognitive Behavior Therapy Basics and Beyond. If people want to know more about it, then there's a book. My father is the first author, Paul Grant and Ellen Inverso, who are on our staff at the Beck Institute, are our co-authors along with a couple of other people. And it's called Recovery-Oriented Cognitive Therapy for Serious Mental Health Conditions. And that's out in December 2020.
Is this the new standard that the Beck Institute will be teaching?
Yes. So we're teaching it along with still teaching the traditional CBT. But giving a rationale for why people might want to try more of a recovery orientation. We really need to have a more solid research before we really give up the more traditional CBT, because there's so much research that shows that it's effective.
Well, you'll never be giving up traditional CBT. You'll just be embedding it in the frame.
That's correct.
How about the hundreds of thousands of people who are now currently CBT therapists? Can they get it from reading the book?
Well, that's a great question because the book isn't out yet. We do have online courses, or we will soon, in recovery-oriented cognitive therapy. And And we do an awful lot of training online for organizations as well. So I think people pretty soon will be able to get a great degree of access to training in this. But, what people also really need is supervision. And we have a terrific faculty who both teach and supervise in both CBT and CTR.
Let's take the experienced therapist. So lots of people will have had years of doing CBT work. They'll be fascinated by the book and eager to learn more about how to apply it to their current practices. Do you think that if you have a good-hearted, great-spirited, smart CBT therapist, that just reading the book by itself would give them enough of a nudge in the direction that would allow them to be practicing this in the way you would like them to?
So that's a good empirical question to which I don't have the answer. I would certainly hope so. The books are pretty detailed in what you need to do and why, and how to implement it with patients. I just found personally so energized by the recovery orientation. I am really doing therapy much differently from how I did it 5 years ago. Although I also expect that 5 years from today, I'll be doing it differently from precisely how I'm doing it today.
It brings up a larger question that wherever I go, the complaint amongst referral sources is always that there's no one in my area who does CBT. That as many people as you've trained and you've filled the crucial niche, not just here, but all around the world, there's a tremendous shortage of CBT therapists around the world. And my guess is that not everyone will be able to take your courses. The question is, can someone go from reading the book, if they have clinical experience, to modifying their practice in a way that will make them more effective therapists? I know you're going to say, because you're always very careful, we don't have empirical evidence. But how about your hunch?
I always think that more knowledge is better than less knowledge. And I certainly over the years have met many, many people who were practicing CBT just by their exposure to the important books. And when I discuss cases with them, they certainly seem to be doing an excellent job. So my guess is that therapists are probably on a continuum to begin with, from really excellent therapists to those who maybe aren't so good. I think the people actually who are drawn to do CBT really have that framework in their mind. It just makes sense to them. Yeah. You said at the beginning of our talk, it just made sense to you. And I think that those individuals probably can get a great deal from books. But, there are also many places in the world where community leaders are learning to do CBT. So these are sometimes in villages in Africa or in other third world countries where, say, the women in the village are taught to do just some very basic CBT skills, such as behavioral activation for other women who are depressed, very basic questioning of their thinking, asking the woman who's in distress, well, what advice would you give to someone else? And they've actually had some really important and very good outcomes. So I think that CBT can be extracted and applied and needs to be reformatted and adapted to the environment, to various cultures, to the diversity of human experiences.
I found myself feeling like I spoke prose without knowing it when I started reading the books. I never had training in CBT, but for better or worse, consider myself able to do it, partly because it came so naturally, partly because I read about it. Yes. And also the Stoic philosophy connection. Your dad mentioned his debt to the Stoic philosophers in the very early papers.
That's right.
Why don't you elaborate on how that comes through? This is not just the wisdom of Tim Beck and Judy Beck, this is the wisdom of the ages.
Of the ages, yes. The Stoic philosophers said that it wasn't events themselves that led to people suffering, but yet it was their perception of these events. And so, these ideas have gone back such a long way. And it applies not only to negative emotion and distress, but also to positive emotion. When we have a positive emotion, it's because we're thinking in a positive way. And that's kind of the bridge, I think, where the cognitive model is the same among both the traditional orientation and the kind of a newer recovery orientation.
There's a lot of controversy in the literature about manual-based therapies, and particularly criticism of people who just stick to the manual. You're the horse's mouth. How do you use the manuals, and how do you recommend that other people use the manuals?
We teach people never to use manuals, that it's important to understand the principles in the manuals and then have an individualized conceptualization of the client and make that treatment right for that client. The manuals are essential if you want to do randomized controlled trials, because you have to make sure that the treatment is standard across patients. And that's why they were developed. But we find that when people use manuals, they just don't fit individuals very well. The individual may have certain preferences, may have comorbidities, may like certain parts of what the treatment is like, might not like other parts. Most manuals, we found too, really don't talk nearly enough about the therapeutic relationship.
Tell us more about that.
Well, I personally think it's an act of courage for most people to enter treatment. And I think therapists are better off if they assume that patients don't feel completely safe at the beginning of treatment, and they do everything that they can to help the patient feel safer. This is particularly important with people who've had negative experiences in therapy before, or people who've had a history of negative relationships in their own life. They may come to treatment with certain negative assumptions, such as, if I reveal my weaknesses, the general beliefs might be, if I reveal weaknesses, people will criticize me and I'll get hurt. If I listen to what other people say, it will show that they're strong and that I'm weak. If I don't assert myself aggressively, other people will walk all over me. And they bring these general beliefs about other people and about relationships to therapy. And so if they believe these things about other people, of course they're going to believe these things about the therapist. And so the therapist has to be really acutely aware of the patient's emotional experience in the session itself. And when clients are starting to look a little bit more upset, it's so important for therapists, not all of the time, but at least some of the time, to stop and just kind of gently interrupt and say, you're looking a little bit more distressed. What was just going through your mind? Now, sometimes the patient is having negative thoughts about himself. For example, I'm too stupid to understand what my therapist is trying to say. Okay, if he is, very important to address those thoughts. Or the patient may be having some negative thoughts about treatment. I just don't feel like this is right for me. And of course, we need to address that. And sometimes the patient is having negative thoughts about the therapist. My therapist doesn't understand me. She's trying to control me. She's telling me what to think. She doesn't believe me. She's being judgmental about me, and so forth. The first thing that we need to do, once we identify patients' negative thinking like this, is to say, it's so good you told me that. Really to positively reinforce patients for giving you negative feedback. Whether it's warranted or not, it's important that they tell you, because if they don't, then you can't solve the problem. So you positively reinforce the patient for giving you negative feedback, and then you have to plan a strategy. Now, sometimes we therapists make mistakes. I remember early on, there was a patient I had, and in the first session, at the very end of the session, I asked for feedback, as I do with every patient. I said, what did you think about today's session? Was there anything that bothered you or anything you thought I didn't understand? And the patient said, no, I think you understood. Yeah, no, I think it was a pretty good session. And I said, and just in case you had any negative feedback, but you didn't feel comfortable telling me, would it be okay if I give you this sheet to fill out? It had 5 questions on it about the reaction to the session. And she said pretty angrily, I hate filling out sheets. So I said, oh, so good you told me that. I think I made a mistake. I shouldn't have given this to you. So I took the sheet and I tore it up in front of her and I threw it out in the wastebasket because I really wanted to demonstrate to her that I would make the session right for her. So it's so important to elicit feedback from patients, either during the session when you notice that the patient's looking a little distressed, and certainly at the end of the session.
The human element is the most important aspect of the treatment.
Yeah. And whenever possible, we positively reinforce patients. So whenever we see them taking even the smallest steps toward getting better, we say, isn't that good that you did that? And again, try to help them draw positive conclusions from it.
I guess the criticism has often been that cognitive behavior therapists are slaves to the manual. And you're anyone who feels enslaved by manuals, you've just freed.
Well, I hope so, because I know that there are some agencies, though, where people are required to use manuals. And I really wish they would require them to use the principles of the manuals, but do an individual conceptualization.
There's a great misunderstanding about the role of manuals in the way the Beck Institute has used them for research, not wanting them to be used slavishly for practice.
Exactly.
If you're following the manual, you're going to be distracted from the patient. So it has to be part of your background knowledge, but not something that's on your mind each session.
That's exactly right.
What about duration?
Duration of treatment?
Yep.
So it varies quite a lot. If there are no external constraints, usually it's just a decision that patients and therapists make together. Once we see that patients are starting to do better, they're taking the steps they need to between sessions, their mood is improving, then the therapist might put it on the agenda to talk about. What do you think about the possibility of starting to space out sessions to maybe once every 2 weeks instead of once a week? And if that works out well for a few weeks, maybe go to once every 3 or once every 4 weeks. So we like when therapy is nearing termination, not to go from weekly sessions to none, but to space them out. And we still like people to come back for booster sessions, even if they're doing pretty well, just to make sure that they're still using the tools that they learned in CBT. Now, sometimes there are real constraints, especially financial constraints. And in that case, it's very important to figure out with the patient maybe what are 1 or 2 goals that are the most important to them, and focus very heavily on those goals in treatment. And meanwhile, whenever we teach them a skill such as how to identify and monitor their thinking, is to teach them how this skill applies not only to this one goal that we're working toward, but to other goals as well. I think it's unfortunate that there are some of these constraints. There's a very interesting system that has been going on in the UK for quite a number of years now. It's IAPT, increasing access to psychological therapies, and CBT is the primary therapy that's used in England. And their system actually makes a lot of sense to me. It's kind of a triage system. I don't know if they would like my characterizing it that way or not, but a patient goes to his GP. GP ascertains that the patient is just very mildly depressed. The patient might be encouraged to take an online self-help course or go to a self-help group or do some readings in self-help. It's not unless they have moderate to severe depression that they might go up a level. And so these would be seeing psychotherapists who are not the most highly trained, but who are very well trained, for example, in behavioral activation for depression. And it would only be the most seriously impaired patients who would see the most highly trained people. So this is one way, and a very important way, to be able to triage care, I think, in a way that makes more sense than we do in the United States.
Maybe you could give us an overview of CBT around the world.
Well, this IACT system is being used in a number of other countries, maybe 5 or 6 countries, following the model that is used in Great Britain. This was established by David Clark and his team at Oxford, and now is used throughout the UK, but in other countries as well. It's very hit or miss in other countries. There are some countries like Scandinavia in which CBT is very strong. And psychodynamic psychotherapy is also very strong. There is still a very strong tradition of psychoanalytic psychotherapy in South America, although CBT has been growing stronger and stronger there in the past 20 years. It's also pretty strong in countries where there was not a psychoanalytic basis to begin with, places like Australia, Japan, China, New Zealand, places like that. So a lot of it actually has to do with what traditional psychotherapy was used, if traditional psychotherapy was used before CBT became established.
I've been amazed to watch the progress of CBT in Japan with
Yes.
Dr. Ono. It's been remarkable. There were 0 CBT therapists when he went back to Japan in the late 80s, and now there are several thousand.
Yes, I remember when he came to study with my dad and me, and he's just done. Dr. Ono has done such a remarkable job in that country, and there are similar people in so many different countries in South Korea, many in China, many in the Middle East. I'm afraid I'm going to leave some countries out, but I have unbelievably wonderful colleagues throughout the world who are so dedicated to disseminating CBT and really keeping a very high bar in CBT. One of the things, speaking of high bar, that the Beck Institute is now doing is certifying people as CBT therapists. And we're also starting to establish a program, although it's not finalized yet, to certify organizations, to accredit organizations in CBT. There are, one of the big problems in the field, and you almost alluded to it before, is that there are so many therapists who say that they do CBT when what they do isn't really recognizable by us as CBT. And so one of the missions of the Beck Institute is really to help people worldwide, to improve lives worldwide through excellence in CBT, innovation, and training, practice, and research in CBT. So we're hoping by raising the bar in certification that people all over the world will be able to reach a higher level of expertise. And as we were kind of alluded to before, I don't think you can ever stop learning in CBT. I'm so much of a better therapist than I was 5 years ago. I sure hope I'm a better therapist 5 years from now. So I think becoming expert in CBT really takes a lifetime. And one of my very important messages in cognitive behavior therapy basics and beyond, and in all of our training, is that you're never finished learning. I still learn from every patient I see, from every person whom I supervise. I learn so much. I'm so lucky to meet even in this day and age with my dad face to face. We discuss cases, and also from my excellent colleagues at the Beck Institute. So I wish everyone were fortunate enough to have the situation that I'm in. But
I think everyone would have been well served to have your dad as a dad.
This is true. He's a remarkable person.
Maybe we should end on that note.
Excellent. Well, thank you so much, Alan, for conducting this interview with me.
Well, I think that what I take from this is that people can adapt what you have to offer to what they already do.
I think that's
the full training.
Yes.
Certainly.
You know, there's almost nothing that CBT would say that you can't do, other than demean patients, degrade them, act superior to them, try to control them, and so forth. As long as you're not doing that, you can work almost anything, adapt almost anything within the framework of the cognitive model.
And just as Britain has a step system with different degrees of intensity, getting different degrees of response in the treatments, in a way, different therapists can have different intensities of exposure to your new model. And some of them may have only the resources to do it by carefully studying the book and then using it, because it's a common sense approach. It's a human approach and should be fairly easily brought into everyone's practice. Beginning trainee to the most experienced clinician. Your dad at 99, not afraid to keep learning, not afraid to keep changing. And other people will be able to avail themselves of the more intense training that you're able to offer. And in a way, the pandemic makes you even more available to people, because more and more people are easily trained and accustomed to virtual communication.
And I think that will continue. I just wanted to add that there's one more one thing that I added two things to this new edition of Cognitive Behavior Therapy Basics and Beyond. One is I kept getting criticized in the first two editions, and rightly so, I think, for using a patient who was too easy. So in this third edition, I have a more severely depressed patient. And I also, throughout the book, follow a patient who's very depressed, who has borderline personality disorder features. But the other thing that I've done that I had wanted to do for many years was to show videos of the patient. So throughout the book, there are opportunities to go to a website to stream so people can actually see what it looks like.
It brings up three thoughts. One is the best way to learn to be a good therapist is to watch great therapists. It's much easier to learn from seeing them in action than it is to reading about them in action.
I think that's
second
right.
thought, that anyone can treat the easy patient. The easy patients get better on their own.
Yeah.
It's the difficult patient that's most gratifying. The patient who's hard for you to treat, who's a stretch, makes you a better therapist. And at the end of your career, you won't remember your triumphs with easy patients.
Right.
You remember the difficult ones. They're the most precious to you in the long run.
And they're the ones who need our help the most.
Say again?
Those are the ones who need our help the most.
Yep. And they're the most neglected. And I think that adapting the treatment to the most severe patient is a wonderful legacy for your dad. How many people in their 90s would tackle the toughest problems in psychiatry and come up with a very, very practical answer that somehow or other eluded most people, going back maybe since Pinnell, who actually saw it the same way.
Yeah.
Pinnell and your dad had a lot in common, and they're two of my heroes in psychiatry.
Oh, wonderful.
And you too, Judy. Thank you so much.
Thanks so much.
Bye-bye.